Okay, great. Okay, so I'm filling in for Dr. Bhatt today. He put together a great set of slides for this talk. So this is our no disclosures. And this is the CE information. Was there anything here that you needed to review around that? No. Okay, this is with each one.
No, thank you.
Okay, so again, no disclosures that I have or that Dr. Bhatt has. So this talk is about the details of the formulation and dosing of buprenorphine. So kind of getting into the nitty-gritty of this medication. The objectives are to describe the differences between different formulations, discuss the difference between protocols of home-based induction versus clinic-based induction with buprenorphine, learn about the dosing and duration of maintenance treatment, and also talk about the management of potential diversion, and then create a plan for managing a process of medical withdrawal from buprenorphine when this need should arise. Okay, so this slide is kind of busy about the formulations. The ones that we'll be talking about are there in the middle, so looking at the middle to bottom, so looking at the tablet form of buprenorphine, both Subutex and then Suboxone, so the mono and dual product, the Suboxone film. The ones on the top, those are used for pain. Oops. I don't know how I did that. I didn't touch anything, but okay. Sorry. And then the implant at the bottom. We've been occasionally using the injectable medication, and I don't actually see that one, the brand name Sublingual, on this list of different formulations. But this gives you a sense of all the different types, and you can see too that for the sublingual tablets, that one in the middle, that there's also different brands, and for instance the Subsolve, which is sometimes one that we use based on the patient's insurance, has slightly different dosing, and we have to get the equivalent dose to our the Suboxone that we're more familiar with dosing. So the buprenorphine naloxone combo product is the one that should be used for treatment of opioid use disorder. The naloxone, again, that's there to decrease risk of diversion. It's not well absorbed when it's taken as prescribed. So when taken sublingually, if it's injected, it will precipitate withdrawal in someone who has tolerance already to opioids, so has opioids in their system and dependent on them. It comes in these different formulations. So there's the film, and it comes in different doses, but it's in that 8 milligram of buprenorphine to 2 of naloxone ratio. But it also comes, that's the one that's typically covered consistently, but it does come also in 12 milligram, 4 milligram, 2 milligram formulations as well. There's also a tablet form, that's the Subsolve, and that's the equivalent dose there that I was talking about to the 8 milligram. And then it comes, and then there's the generic tablet form of Suboxone, which is the same as the film dosage. Again, we're just going to use the mono product in patients who are pregnant and try to avoid it otherwise due to increased risk of diversion. If they have a documented allergy to naloxone, this rarely occurs, but when it does occur, that would be another reason to avoid it. And sometimes people think it's an allergy when they felt bad trying Suboxone before, and if you kind of dig into that a little bit more, it's more that they had some precipitated withdrawal. And sort of, if you can kind of sort that out, then oftentimes they can try it again under your supervision. So what about film versus tablet? It's generally largely driven by third-party considerations, so what the pharmacy has available and what the insurance will cover. The film tends to dissolve quicker, so in less than 5 minutes, excuse me, versus about 10 minutes. And when it is individually wrapped, which can possibly reduce diversion risk, and also that was with safety in mind, so that it would be harder for individuals to get into it who shouldn't be. Such as kids. And our buprenorphine treatment options involve self-administration, so the sublingual form, and then the injectable. And here you can see listed the differences in terms of why someone might choose one over the other. The self-administration, so the sublingual form, it is the current standard of care. We don't have as much experience with the injectable form. Oh, it jumped again. I'm doing that. Just get away from. The self-administered form has many doses and formulations, as you saw, and there is a growing number of doses and ways to administer the injectable, but as of yet, there's not the same variety. The self-administered is widely accessible. Injectable is closed distribution, so it needs to be sent to the pharmacy to be administered in the clinic and not in the patient's home. Self-administered has increased potential for diversion, and the benefit of the injectable there is the decreased risk of diversion. So oftentimes that's when it may come up clinically to consider that as an option. And then certainly the costs are higher of the injectable form, which is why sometimes it can be more difficult to get that covered. Okay, so let's talk about home induction. Is it feasible? Is it safe? Is it effective? Yes to all. I guess there's an exclamation point there for each one. So Josh Lee, I believe, is out of NYU and had a great study several years ago, and this is his 7-year outcomes that are not published yet for an N of 485, and it was a similar population from what I remember from the original study in terms of racial diversity and insurance, largely Medicaid, to our patients that we see here. At week 1, dropout. Now these are the percentages for patients who started the induction at home, and what was found was that they were at least as effective in these measures as the in-clinic inductions. And so there was week 1 dropout of 17%, the induction-related adverse events at 12%, and then the serious adverse events of 0%. Precipitated withdrawal was relatively low at 3%. I don't know what the comparable comparison was for the in-clinic induction in Lee's study, but I will say just based on experience, it is much harder in clinic to not precipitate withdrawal because you have to get the patient there right at the right time, which can be hard to do. Experience of prolonged withdrawal at 4%. And then possibly most importantly, the median treatment retention at 57 weeks was also at least as good as the in-clinic induction. So with all of this information, we were, you know, when the DEA first, when the FDA first approved, and we got the DEA waiver back in 2000 with the data waiver. Around then, when we started training, we did a lot of focus on in-clinic induction, and it's really shifted to pretty much all home inductions, especially it's just much more feasible in primary care settings. So what is the process? I actually tried to click on this link and it came up as a closed link, so I'm not sure if other people are able to pull up the handout here, but there are good patient handouts, I believe, also on SAMHSA for at-home inductions. For patient selection, almost everyone would be able to do this. You could consider excluding the following people. So consider patients with low tolerance. So that might be somebody who has not taken opioids in quite some time, and they still qualify for opioid use disorder criteria, but so they're needing to start buprenorphine, but you're worried about their tolerance and you want them to be monitored. They might be someone, I wouldn't say that this is everybody who fits that. We'll oftentimes with our at-home instructions explain a slower induction than what we typically would do with someone who's already tolerant and going through withdrawal. So perhaps going from 2 to no more than 4 milligrams, for instance, on the first day. But this would be someone that you could consider doing in clinic induction. Patients transitioning from methadone, those transitions tend to be some of the most complicated just because of the long-acting nature of methadone. Patients can do these inductions as well as with the prior situation. They could do them at home, but if possible, it's preferable in clinic. And also, we're happy to talk with you about this too if you have someone who's going through it at home. Patients with cognitive impairment, untreated psychiatric conditions, severe conditions, suicidality may be referred in that moment to the hospital, but also these patients, in terms of their ability to follow the instructions closely at home, they may be someone that you prefer to have do it in clinic induction. And then patients with no prior buprenorphine experience, I would say the second point, the significant fear of withdrawal, sometimes those folks just would opt to have you walk them through it, and if it's not something that's available in your clinic to do in-clinic induction, might be something like that you could refer to a treatment center such as ASAP, and then we could stabilize that person and help get them back over to you. So these are the instructions that we go through with patients, and we give them a handout as to how to go through the induction at home. And I will say that most people, well, a lot of people have already tried buprenorphine when they're coming looking for help. They've either tried it from a friend and maybe it has or hasn't gone well. They've had precipitated withdrawal or not. And so you're having that conversation at first. And I think that even in someone who is experienced, it's good still to go over these instructions with them and if possible, give them a handout as well. So we explain that it's really important on day one to wait until they're feeling very lousy. So really in some significant withdrawal, if they think that they're feeling crummy, see if they could wait a little bit longer to make sure they're in significant withdrawal. So this should be at least 12 hours since the last use of short-acting opioids such as heroin, and at least 24 hours since the last use of long-acting opioids. And again, this is different than with methadone. Those transitions are a little bit longer. Can't remember if he has a slide on that, but if not, we can talk about that if you'd like more information. And so if the person seems interested in having the actual scale to look at, if that's sort of helpful for them or perhaps for their support person to have, you could also provide the opiate withdrawal scale and explain that the target score should be at least 17 on that scale. Once they've, and I'll also just say that I also talk with people about the pupil dilation being a really reliable sign. So looking at their pupils when they're, they've recently used, and then so they have a sense, looking in the mirror what their pupils may look like then, and then waiting for them to dilate, notably. That's usually a really reliable sign in addition to these other things. And then in someone who is tall, then we would start with a 4 milligram dose typically. And so you'd instruct them to take half of that tablet or film and then wait about an hour, and probably at that point they should be starting to feel a little bit better but may still have some withdrawal symptoms, so they would administer the other half under the tongue. And they keep doing that every 1 to 3 hours if their withdrawal continues, for a total dose of 12 to 16 milligrams on day 1. If they precipitate withdrawal, also reviewing with them that it's a good idea to call the clinic, and we also give them information on that too, which I believe is coming up. Oh, and this is just a review of the, I don't think there's anything on the top there. Is there any way to get the bar to move? Oh, thank you, I can see it better there. So this is, just a review with the patients of your COWS scale. So these are things that I also like to go over with people, because when we're sending them home with a prescription, it's also nice to offer a prescription for some of the uncomfortable symptoms. And so if they have, you can ask kind of what are your symptoms that you typically experience with withdrawal, and kind of proactively, perhaps it's nausea, or proactively help them with some prescription that may also help them through the process. Okay, so then let's say you explain to them they've gotten up to the 12 to 16 milligrams on day 1. And it may be less. It might be that they feel completely fine at 8 milligrams, and so they won't continue to take it. But even if they feel fine at 8 milligrams, let's say later in the day, they've gotten out of that 1 to 3 hour period, maybe in the evening they're starting to withdraw, it would be fine then to take the the next 4 milligrams. So it is within that first 24-hour period what their total dose will be. Shouldn't be more than 12 to 16. And then the next morning, they're going to wake up and take the total that they took on day 1 in the morning. So that's important to walk them through so that they don't continue to split the dose. And contact the clinic to check in. That's nice if you have a support person, perhaps your MA or kit, to call and check in on the next day. Now on day 2, if they do start to feel like they have withdrawal later in the day, which especially kind of getting over that hump of the initial transition off the opioids, they may in the first few days actually require even a higher dose than their maintenance dose. But so if they have a withdrawal, then they can take additional 4 milligram doses until comfortable or until the maximum of 16 milligrams is reached. So I think what Dr. Bott's getting at here is if on day 1 they took 12 milligrams and then day 2 they take 12 milligrams in the morning because that was their total, later in the day they may start to feel withdrawal. We don't want them suffering through that. They need to know it's okay to take an additional 4 milligrams for a total of 16. And then day 3, they will again take the total dose that they took on day 2. And that probably at that point is going to be what will be their stable dose until you see them back. And you're going to provide enough for 1 week. So we try to get them to their target dose, which again, based on what we know about receptor availability in folks who are opioid tolerant, is probably going to be 16 milligrams relatively quickly. So in the first couple of days. It may take more days than that to really feel completely stable, just because it takes some time for the transition to occur. And then after that, you want to wait for a good week or so to assess again for that sort of stability before adjusting the dose beyond the 16 milligrams if possible. Now, what I just said about sometimes people do need it slightly more in the first 24 to 48 hours. I have had cases where people have gone up to 20 milligrams and then stabilized at 16 milligrams because we've checked in with them and that's been determined to be safer than them feeling like they're craving and possibly going to relapse in that first early period. So that's why the check-in is really important. How long to wait? So this goes back to that earlier slide. For short-acting opioids, again, a goal about 12 hours, longer-acting 24 hours. Methadone, you need to wait 36, 48, maybe even 72 hours completely off of methadone, and that's again after they've gotten down to 30 milligrams or less on their methadone. Transitions can happen more quickly, but in an inpatient setting usually. And then it's always possible to precipitate withdrawal, and so it's really important to talk about it ahead of time because we can treat it and we want to still push them through so that they will stay on their buprenorphine. So here is a slide about transitioning from methadone. And he has here, so 40 milligrams or less, so 30, 40 milligrams or less for at least 1 week, and then no methadone for at least 48 hours. Again, if they can wait up to the 72, that's likely to be less risk of a precipitated withdrawal. It's important to provide medications for symptom management, and I would suggest you can provide these too for the shorter acting transitions, but definitely for methadone, some of the options would be clonidine to help with that kind of feeling of anxious, ibuprofen, cramping, loperamide for diarrhea, trazodone for sleep, hydroxyzine for anxiety. Those can all be helpful. And then same thing as we talked about with the shorter acting induction, starting at 4 milligrams once in withdrawal and moving up. Sometimes with methadone in our in-clinic inductions, sometimes we'll go even slower, starting at 2 milligrams. Just because it just can take a little bit more time for that shift to occur and you're less likely to make them feel as uncomfortable. So what do we do if we precipitate withdrawal? Again, it's helpful to talk about this ahead of time, not to scare them, but just so that they're prepared in case it does happen. And if this does happen, it is important to continue with the buprenorphine to get them through it. I think when I first learned about this, the idea was hold off, wait, try again in a day, and I think some of the literature out there might still show that. That really increases risk of relapse and possibly losing someone to treatment, and so we really want to try to push them through the withdrawal. Again, if someone's really concerned about this happening, or perhaps they've experienced it before, then it might be better to do this in clinic with them. Again, making sure to consider the medications for symptom management. Okay, so in the last few minutes, we'll talk about maintenance dosing considerations. And tell me if you see. Okay, so we're getting there though. So the maintenance dose, FDA approved maximum is 32 milligrams, but we rarely dose that high. Most insurances will cover up to 24 milligrams, and that really is clinically the recommended maximum, and that's because of that receptor availability. Really, we see that plateau out at the 24 milligrams, and there's really not a whole lot of shift in terms of receptor availability above 24 milligrams. Most people stabilize somewhere at 12 to 16 milligrams. 16 to 24 milligrams is really what's been shown to decrease positive eutoxes once someone's on a stable dose. Just keeping all of that in mind to make sure that someone is on a sufficient dose is important. And it's here to keep track of your mean median mode in your clinic. Not exactly sure, but it's important to kind of have a sense, I think, of what your clinic patterns look like to make sure that you're kind of not, I think for sure, not exceeding the 24 milligrams. So if someone stabilizes after those first few days at above 16 milligrams, if they've gone up to 20 or 24, then we like to consider having a conversation with them about trying to decrease by 2 to 4 milligrams at a time to a target dose of 16 milligrams after they've been stable for several months, simply because they might have, again, gotten over that hump of the induction, and actually the receptor availability doesn't change a whole lot between those doses, and so people may find that they actually are as comfortable and not craving and withdrawing at a slightly lower dose. So many people can tolerate this. Sometimes education on that sort of dose response curve that I was talking about in terms of receptor availability can be helpful. Talking about some coping strategies, so sometimes it's some of the mindfulness and some of the therapy techniques can be really helpful in terms of making that slight decrease. And then talking about relapse prevention and triggers, and also that if they have worsened cravings or withdrawal, then we'd want to continue them at an effective dose. So it's possible that they may want to try to decrease to that 16 milligram, but actually come back and see you. And I would certainly say too, to shorten the prescription if you are making a transition like that, so they may not be out there for a month without you knowing that they're uncomfortable. Have them come back in to check in sooner, and really if it didn't go well, then to kind of perhaps stabilize at their prior dose would be appropriate. To split or not to split? So in general, we recommend daily dosing, sometimes twice daily dosing if the patient prefers that. For underlying chronic pain, consider 3 times a day dosing. Sometimes these folks do better on the slightly higher doses because as a secondary treatment of pain. Again, your primary reason for treating them with the X waiver is the opioid use disorder, so that will still be mainly in your evaluation and treatment and documentation, but it can help, that dosing schedule can help with pain. And breaking the condition preference for throughout the day dosing is very important for recovery. Yeah, so a lot of people will be used to taking an opioid several times a day. So for instance, they may have been injecting heroin 4 or 5 times a day. And so if we're helping them shift to a once daily dosing, it can help break that cycle where they're having to like constantly be looking for it or possibly leaving work, things like that. That transition can also be kind of scary for people sometimes too, because it's a pattern that they're used to, and so it's helpful to kind of have that conversation ahead of time as well, and see how they're doing with that. That's when the therapy can also be quite helpful. How long to give the prescription for? This is really tied to how the patient's doing in their treatment. If they're kind of meeting their goals that they want to meet, more than like time in treatment, there's no script for this. What we tend to do is start with weekly prescriptions at each visit for about 4 weeks, then go to 2-week prescriptions for, again, about 4 visits, and then monthly again for a little while, and then monthly with a refill. I know from my work in the community and from talking with other providers that in community sites, you might move through this a little more quickly just based on your availability, but then maybe checking in over the phone with the patient, and sometimes going up to a month and 2 refills in our very stable folks. So this again is based on the patient, how well the patient's doing, and what works for you as the provider. In terms of diversion management, it's important to do your urine toxicology screens. We do them at each refill. Again, this isn't a rule, so it's kind of you need to decide as a clinic, but our practice is to check at each refill, and we check for buprenorphine in addition to other substances. We check the PMP at each visit, and this is something that you have to do if you're prescribing more than 4 days. We have 48-hour callbacks, and this is not a requirement. This is kind of hard, I think, in some settings to do, but it is an option, and what this involves is our nurses keeping an active list of our patients on buprenorphine, and if they have a longer prescription, so more than a month, in fact, at our clinic, it might be longer than 2 weeks, but I think longer than a month, then having a call about 1 or 2 times a year, and they are aware of this. So when they start their prescription with us, they get information about this, and they know that they need to tell our clinic, like if their number changes or if they're planning on being out of town for a while, and they need to come back with their remaining medication for a count. And then we also recommend safe storage with lock boxes. Oh, this is going into the detail about the 48-hour callbacks. It's part of their agreement, the updated number. Our MAs call 3 times in a 24-hour period. The patient has 40 hours to come in. And then I didn't say that in addition to the pill count, they know that they will be giving a tox screen then, and with that tox, we also send ours for buprenorphine metabolites, just to check for potential that they may not be taking it. Or the other thing is when the metabolites aren't present, it's oftentimes more likely that they're taking it, but they may have brought someone else's urine in because they didn't want us to see like the cocaine or something else in there. But they're actually taking their buprenorphine, but melted some into someone else's urine on that day. So there's different things that can happen, and this is just kind of, again, part of the picture to sort of help us all be on the same page about what's really going on with their recovery and how we can help. What about maintenance therapy duration? There's no data on how long to treat someone. Studies, though, just show as long as 16 weeks show really high relapse rates with medical withdrawal. Brief withdrawal periods are not likely to result in long-term abstinence. And then studies do show patients retain long-term at 1 year with maintenance, doing well in terms of their sobriety and recovery, and it's really recommended to stay on these medications. So we want to continue maintenance as long as the patient's benefiting from treatment, and the benefit is really in terms of their wellness. So they may define that in terms of employment, their drug use, education goals, improvement in relationships, improvement in other health conditions, and engagement in psychosocial treatment. So when someone comes in, oftentimes their first question may be, how long do I need to be on this? And I never want to frame it in terms of a time frame, but more in terms of their personal goals. And also making sure that they're not feeling pressured to get off of it. Sometimes there can be internal pressure, but oftentimes it can come from family members, friends, other medical providers, so it's good to try to talk with people about that. They may feel a sense of, they may seem like there's an urgency to get off of it, and then after you talk with them more about it, they may feel relief actually that, oh, there's not pressure to get off of this. Study from Lang in 2009 in terms of withdrawal, what there's not a consensus as far as what length of withdrawal is more helpful. So buprenorphine, no difference in 7 versus 28 day. And the 1 month opioid negative urines were low. Let's see, 18% and 12% at 3 months, 18% and 13%. So there was no advantage of 28-day taper over a 7-day taper. I will say that just anecdotally for the folks who are really wanting to get off of this and they've been stable for a long time, and I see this a lot in our younger folks too, when they want to get off of the buprenorphine, and it seems like the right thing to do for them. We always have the conversation about risk of relapse, and that they can certainly come back and see us again if they, at any point, but that they tend to prefer the gradual taper. I do see, yes. Okay, so we'll wrap this up. Thank you. And then risk of overdose is greater with withdrawal because of loss of tolerance. And so it's always important to make sure that you continue to prescribe naloxone. And those undergoing medical withdrawal should be warned about the risks. And if withdrawal is done, it should be once functional goals are met. So again, not time frame, more stable social networks, and gradually at their own pace. And encourage them to remain engaged in therapy, especially after they've not been taking the medication, because that is a high risk time. And then there's also a point here to consider injectable naltrexone upon completion of withdrawal. So are there any questions? I did see that David, I think, signed on, and he might